Our next speaker is Dr. SAYALEE LAHANE. She'll be having two talks. First is on surgical management of endophthalmitis A to Z and scary stories of endophthalmitis. Dr. SAYALEE has done VR fellowship from Shankar Netralaya, and she's at present working as associate professor in the Department of Vitreoretina in JJ Hospital. Over to Dr. SAYALEE.
Good morning, everyone. So my topic for today is surgical management of endophthalmitis. All unexpected inflammatory response following an intraocular surgery should be considered endophthalmitis unless proven otherwise. The commonest presentation is a non-improvement in vision to the anticipated degree accompanied by an unexpected inflammatory reaction. So when do we do vitrectomy? When there is no improvement or actual worsening of the condition clinically after 48 hours of conservative management, absence of fundal glow on initial presentation, suspected fungal infection, bleb or trauma-associated infection, retained intraocular foreign body, and chronic endophthalmitis with remissions and exacerbations are some of the indications for vitrectomy. What is the rationale of vitrectomy in endophthalmitis? Basically, it removes the bulk of infected material. It reduces the bacterial load. It removes the exotoxins and endotoxins. It provides a material for microbiological tests so that we can identify the organism. It gives better access to antimicrobials and early clearing of the media. For vitrectomy, the procedure is done under local anesthesia. Standard 3-port technique. First, we have to collect the vitreous specimen before starting the infusion so that we have a high yield of organism if possible. Limited core vitrectomy or vitrectomy to the extent possible depending upon the visualization. Intravitreal injection of antimicrobials and steroids if it's not a fungal endophthalmitis, and silicone oil injected as and when required. So I'll be sharing a few videos here. I'm sorry. Here, this is a case of endophthalmitis where I'm doing vitrectomy. You can see the vitreous exudates. The view is very hazy, and you have to do vitrectomy as and whatever extent possible. In every case, you may not be able to induce a posterior vitreous detachment in endophthalmitis because the retina is edematous, and many a times the vitreous is very much adhered, and there are chances that you may develop retinal tears. So in such cases, we have to avoid pulling the vitreous from the retina, be very careful and patient, and do vitrectomy to the extent possible. As you can see, there are a lot of hemorrhages on the retina, so there is retinal involvement. This is fluid gas exchange being done, and whenever there is involvement of retina in an endophthalmitis patient and the endophthalmitis is severe, we usually prefer to inject silicone oil in these patients, and we have seen over the years that the results are much better. We don't need, many a times we don't need any re-injections or we don't need any re-surgeries when we use silicone oil in such patients. So in this patient also I have injected silicone oil because the retina was quite involved. This is one more case where the anterior segment reaction is much more compared to the earlier patient, and first and foremost is see if the wound is healthy or not, and if the wound has any gape, then it has to be sutured. In any endophthalmitis surgery, make sure that all the wounds are sutured well, because that's usually the entry site from where the infection has entered. And then we have to clear the anterior chamber, remove all the fibrin with the help of cutter or with the help of syringes for aspiration. And you can see that the posterior segment is not very bad in this patient. The way the retina looks quite okay, it's quite healthy compared to the kind of anterior segment reaction this patient had. So here, after doing vitrectomy, I have just done fluid gas exchange and not injected silicone oil, and the patient has done well post-operatively. So this is the fluid gas exchange being done. This is one more case where the anterior segment reaction, the hypopyon was very thick and it was almost filling the whole anterior chamber. And sometimes you feel that in such cases you may not be able to see anything, the cornea is very bad. But once you clear the anterior chamber, you the view, and the corneal edema also reduces. Sometimes the pupil also gets dilated after you remove the anterior segment reaction and the fibrin, and the view gets much better for you to operate. So what are the problems which we face when we are doing vitrectomy for endophthalmitis? The main problem is visualization, and the IOL, whether to keep the IOL or to remove the IOL, which antibiotic to be used, whether there is any association of RD, and in vitrectomized eyes with intraocular tamponade. So visualization. Basically, initial vitrectomy, if you're not able to visualize, you can do it with bent cannula or anterior chamber maintainer until the infusion cannula is clearly visible. So never start the infusion cannula immediately in a patient with endophthalmitis, because the tip may not be visible many a times. Do only as much vitrectomy as is safely possible. Avoid scleral depression and base excision as far as possible. Corneal edema and infiltration, if it is causing any problem, you can just scrape the corneal epithelium and the visualization will be better. Temporary keratoprosthesis or combined PK when the cornea is very bad and you're not able to have a posterior segment view. The intraocular lens, anterior chamber wash with removal of the membrane over the IOL has to be done before proceeding with vitrectomy. The IOL may not be sacrificed in every case of pseudophakic endophthalmitis, but it becomes necessary in gross infections of gram-negative organisms and sometimes in fungal endophthalmitis. P-acne endophthalmitis, you have to perform a generous capsulotomy, either to retain the IOL or exchange the IOL, and if possible, inject intraocular antibiotic, especially vancomycin, in the remaining part of the capsular bag, because P. acne are sensitive to vancomycin. Chronic resistant endophthalmitis and sequestered organism, if you are suspecting it within the bag, and if the patient is requiring resurgeries for endophthalmitis, then you may think about removal of the IOL with entire capsule. Unusual situations, if the scleral tunnel is involved, you may need a sclerocorneal patch graft if there is melting. In presence of filtering bleb, change the position of the sclerotomist to avoid damage to the bleb. If scleral buccal is present, then sometimes we may have to remove the scleral buccal so as to remove the exogenous source of infection. Postoperative management, we have to watch the patient very closely for improvement in the symptoms such as pain, analgesics if necessary, topical systemic antibiotics, antifungals or steroids, topical cycloplegics, repeat AC tap and intravitreal injection if there is persistent inflammation, if there is recurrent vitreous fibrin, and if persistent media opacity is there. And usually, if you have operated the patient and you have injected silicone oil in that patient, many a times it is not required in majority of the patients. The signs of improvement: reduce pain, decrease inflammation and hypopyon, increase red reflex, retraction of any fibrin, and improved visual acuity. These are the signs of improvement. When do we need a resurgery? It is required if there is reaccumulation of exudate. Suppose if we had done a core vitrectomy, PVD has got induced, then you may need post-PVD to complete the vitrectomy. Resistant organisms where repeated intravitreal injections do not have any effect. Optical purpose for the infection is controlled, and if there is rhegmatogenous RD or ERM formation, which is secondary after the patient has come out of the endophthalmitis. What are the poor prognostic factors? A positive culture, then a highly virulent organism, the sensitivity of the organisms, then duration of infection. Increased duration between the onset of the disease and the therapy is a poor prognostic factor. Initial visual acuity less than 20/400 is again a poor prognostic factor. Concomitant ocular diseases like RD, rubiosis, PVR, host response to the organism, and any associated macular edema or submacular exudation again has a poor response or poor prognosis. Endophthalmitis vitrectomy study is a multi-center trial which was done in 1995, wherein they found the role of immediate vitrectomy and systemic antibiotics in management of early post-operative endophthalmitis. Actually, my talk duration is 10 minutes and the next one is 7 minutes, so I'll be combining the two talks together. Role of immediate vitrectomy and systemic antibiotics in management of early post-operative endophthalmitis. Here they evaluated 420 patients and the follow-up of 9 months was there, and the conclusion of the study was systemic antibiotics have no role in the management. Visual acuity more than PL, routine immediate vitrectomy is not needed, and if it is only PL, then vitrectomy is of substantial benefit. But are the findings of EVA study still relevant today after so many years? The toxins and the cellular influx, which can still damage the retina and limit the visual recovery, even if the infection is brought under control with conservative management. Late intervention leads to poor results, like 6% of the patients had phthisis or enucleation in EVS study, and only 53% patient had more than 20 by 40 vision in EVS study. Now with the improved techniques of vitrectomy and improved and much better visualization system, I feel early vitrectomy gives better anatomical and visual results. So on conclusion, endophthalmitis is a devastating complication of intraocular surgery, and visual outcome is directly related to early diagnosis and appropriate therapy. Thank you for your patient listening.